Hi, I'm Joe Broderick. I'm the President-elect of the Stroke Leadership Committee, and we're here to talk today about the MR Rescue study. Joining me today is Dr. Chelsea Kidwell, who is the PI of the MR Rescue study, and I maybe have her say a few words about herself and also about the study.
Hi Joe, I'm Chelsea Kidwell. I'm a professor of neurology at Georgetown University.
Chelsea, first of all, maybe just tell us, what was the MR Rescue trial intended to do? What were you trying to find out?
So we had two main goals with MR Rescue. First, we wanted to show that advanced imaging can identify patients with a penumbral pattern who are most likely to benefit from endovascular therapy. Second, we wanted to show that patients treated with endovascular therapy within 8 hours of onset have better clinical outcomes compared to standard care, regardless of imaging pattern.
Now, penumbra is something we use in common language, and even for physicians, though, we may not know what a penumbra is. Can you maybe tell people about what the penumbra means in the study?
Well, the simplest way to describe the penumbra is salvageable brain tissue. And so we're looking at whether patients with substantial amounts of salvageable brain tissue at the time of imaging and enrollment are going to have better outcomes if treated with embolectomy.
Wonderful. So tell us a little bit what you found about the study, so how the study went, and what were your findings?
So first of all, just mention that MR Rescue was a randomized, controlled, blinded outcome trial. Our target sample size was 120 patients. We enrolled 127, but 118 met full eligibility criteria. For our primary analysis, looking at whether there was an interaction between imaging pattern and treatment assignment, that was our test of the imaging selection hypothesis. That actually showed that there was no significant interaction. So we were not able to show that penumbral imaging selects patients most likely to benefit from endovascular therapy.
Now, did that surprise you?
It did surprise us. It was a disappointing finding, but we found absolutely no interaction. Furthermore, we didn't find that patients treated with embolectomy compared to standard care had any different outcomes at all. So both hypotheses were negative.
So I know there's a lot of people in the field who are very invested in using penumbral imaging, looking at ways of trying to identify salvageable brain. Do you have any thoughts about why your original hypothesis was not found to be the case? And then do you have any ideas about how you would maybe go forward from here?
Absolutely. I think there's a number of things to consider. It is possible, when you look at the outcomes in MR Rescue, the penumbral pattern standard care patients had the best outcomes. It may be at the late time windows. If you have a penumbral pattern, you have a lot of collateral flow, and that keeps the brain tissue alive until spontaneous recanalization occurs. So it may be that we need to identify patients earlier for penumbral selection. I think we also have to keep in mind that MR Rescue was performed with first-generation devices with lower recanalization rates than the stent retrievers. So we need further randomized trials, both to test the full spectrum of the penumbral imaging selection hypothesis and to test the new stent retriever devices compared to control.
Now, one nice thing about the study is you had ways of looking at whether the arteries opened up, whether or not you got the embolectomy device, even got standard of care. What was the difference? How well did the embolectomy devices do in terms of opening up the artery? Because that's, no matter what technology we're talking about, that's what the goal is. So how did they do? So
the revascularization in the embolectomy arm was 67%, which is pretty similar to rates found in prior trials using the Mercy Retriever and Penumbra system. But it's not as good as the newer trials, the Retrieval and Solitaire devices. So we probably have some room for improvement there. We also did imaging at day 7 in all patients, and we found that revascularization at day 7, regardless of treatment assignment or imaging pattern, improved clinical outcomes. So we're seeing that revascularization at that late time point is a good marker of good clinical outcome.
How did the revascularization compare in the endovascular, the patients who got the Mercy Retriever and Penumbra compared to standard treatment? How did that compare?
We did not have early imaging in the control arm, so we can't answer that question. We only have the day 7 imaging.
Bummer.
Correct.
So any kind of words you would want to share with physicians in stroke and other ways about the future of penumbral imaging or imaging to look at salvageable brain?
I think that we still have a lot to learn. I think it's still a very promising approach, but we need to have randomized controlled trials testing the full selection of penumbral imaging. I think it is a little premature to start trials that assume that we know what the best imaging pattern is and only enroll those patients. We still have a little ways to go before we're there yet.
Wonderful. Well, thank you so much, Chelsea.
Thank you, Joe.